Today we're going to build on those prior lectures by covering stereotactic procedures, namely stereotactic radiosurgery, so in the brain, and then stereotactic body radiation therapy, which is outside of the brain. And it's really a privilege to be here to speak with all of you on behalf of RCC. I'm so happy that you have chosen to give up some of your personal time to join us. And I want to let you know that today really is a bonus for all of you because we have Dr. Lin on the line with us. She works at UT Southwestern. They are absolutely a leader in the United States with these techniques. She works with Dr. Timmerman and others. And so as you're thinking of questions for me, also think of questions for the moderator, and we'll try to tag team those questions. So that being said, let's go ahead and get started. Okay, so SRS and SBRT, with SBRT sometimes being called SABR, meaning stereotactic ablative radiotherapy, these techniques are different than conventional radiotherapy. And how are they different? So one, there's a higher dose per fraction with the stereotactic procedure, somewhere in the range of 5 gray per fraction when the target is near some radiosensitive organ at risk like the bowel, all the way up to 85 gray per fraction in a single fraction to, say, trigeminal neuralgia in the brain. Doses could even be higher for functional disorders like Parkinson's tremor. And so this means that normal tissue toxicity could potentially be an issue at lower isodose lines than with conventional radiotherapy plans. Moreover, there are a limited number of fractions. So this provides fewer opportunities to recover from a mistake. Margins tend to be tighter, somewhere in the range of 0 to 2 millimeters for SRS, perhaps 5 millimeters or smaller for SBRT. And so this really places greater importance on the accuracy of the contours, the image registration, and immobilization. Treatment fields tend to be smaller, dose gradients tend to be steeper. And so this places increased demands on the equipment, the beam modeling, and the quality assurance procedures to ensure that we don't miss. There needs to be some redundancy in the high resolution detectors for the beam modeling and the QA, daisy chain approaches across multiple detectors, comparisons with identical machines, and end-to-end testings before engaging in patient treatments for SRS and SBRT. Moreover, specialized expertise is required across the team members, and these team members must be trained on SRS and SBRT. And this is often a gap that prevents implementation in clinical practice. The physicist is responsible for the technical aspects of SBRT and SRS, and the physicist must be available for consult throughout a case, from simulation all the way through treatment. Physicist personal supervision is recommended for the first fraction and is even necessary for portions of the subsequent fractions. And some of this guidance is laid out in the AAPM Medical Physics Practice Guideline 9.A for SRS and SBRT. So a good reference for you all to consider. Prior to any treatment plan checks or patient treatments, there is an implicit expectation that a stereotactic LINAC is commissioned and that a well-documented QA plan and program is in place. LINAC tolerances for SRS are more stringent for SRS and SBRT as compared to conventional RT. Again, you can reference some of these requirements in the MPPG 9A report. Okay, so let's talk a bit more about that outline in terms of treatment planning checks for SRS and SBRT. First comes the patient assessment and intent, then simulation, then the treatment planning process, followed by communication, and then what to do if there are any deviations. Patient assessment. So it's very important to review the background information about the patient and to understand the physician's intent. You may review the patient's medical history in the consultation report to have context for the current plan. And so why would we do this? Well, for one, the target may not be obvious to a physicist. So here's a case study shown in the figure at left. This is an example of an SRS case for trigeminal neuralgia. And this plan has a maximum dose of 85 gray. And that 85 gray is perfectly centered on the right trigeminal nerve. So by all accounts, this looks like a really great plan, but there's a problem. And that problem is the patient has left-sided trigeminal neuralgia. And if we're not looking at the consultation report, we're not going to know that just looking at the dose and its overlay on what seems to be a plausible target. The physician intent for SRS and SBRT may either be definitive or palliative. It's important to know which is which. And the prescription dose may vary based on the disease site, the target size and location, the physician's intent, and any prior radiotherapy. The physicist's knowledge of SRS and SBRT literature is so important in order to evaluate the physician's prescription. So you really need to do a literature review by looking at clinical trial protocols, TG 101, high-tech, and other literature, which we'll touch on more later, in order to evaluate the prescription. Okay, now we may also need to look for any special planning conditions early in this plan review process. And so the presence of these special considerations may change the way in which we review the plan. So what are some examples? One example is an implanted device. So for example, a cardiac pacemaker or a defibrillator. The guidance for that we follow is in the AA-PIM Task Group Report 203. Patients may also have orthopedic hardware that could be close to the treatment field. And it's so important to know the material, and that's because the same size screw could be made of cobalt chromium, a titanium alloy, or stainless steel. And if the CT value saturates, it's not really easy to know what that is just based on Hounsfield units. Patients may have medical conditions like anxiety, claustrophobia, kyphosis, they may be in pain. And all of these things are considerations because we need to have the patient comfortable in a position where they can hold still for the duration of treatment in order to very precisely and accurately guide a very high dose to the target without missing it or over irradiating a tissue nearby that's radiosensitive. And what about prior radiation? So this really needs to be considered so that we can avoid an overdose, so that we can optimize the treatment of the current plan and to ensure patient safety. Up front, it's important to know if the patient's had any prior radiation therapy treatments, and then to obtain the treatment summary report from the prior RT in order to know the delivered dose and when that dose was delivered in order to account for any healthy tissue repair. And we'll touch a bit more on that later. It's important to assess the potential impact of that previous irradiation based on the proximity to the current disease site. So if that prior RT is close, meaning that it abuts or overlaps with the current plan, then we really should obtain the RT DICOMs, so the CT images, the RT dose, even the structure set and plan, in order to more accurately model that prior radiation in the treatment planning system. Okay, so now let's move on to the patient simulation. For intracranial SRS, historically, those patients were immobilized using a head frame. And so this head frame is physically screwed into the patient's skull, so very secure. And the head frame defines the coordinate system. So this really is the essence of stereotactic, that is, precise and accurate 3D localization. Now, the figure at the bottom right shows how this was done about 30 years ago at Emory, where I work, in which case the patient was immobilized with a head frame and then positioned upright in a chair. And then that chair was rotated about a vertical axis while the gantry remained stationary in order to administer an arc of radiotherapy for SRS. The gantry was then rotated, and then another arc was delivered. Since that time, both at Emory and at other institutions, more and more radiosurgery on a LINAC has moved from frame to frameless. And so by frameless, what I mean is that the patient is now immobilized in a thermoplastic or an aquaplastic mask, as shown at left. And so using this technique, the head needs to be level. The mask needs to be in very tight contact at the forehead and at the chin. The posterior head and neck should be very much conformed, either using a custom headrest or a custom pillow or bottom shell that has no folds or kinks in order to have firm contact. If the patient has long hair or facial hair, then that needs to be managed. And so by managed, I mean that the long hair could be pulled out of the hole in the mask so that it is not making contact with the mask. And further, the patient needs to be advised to avoid haircuts during treatment. So if we start out with a patient who has a lot of hair, and then that patient shaves their head or has a significant haircut, the mask is no longer going to be firm and secure. And so that presents an issue with immobilization. If a patient has hearing aids, those may need to be removed prior to simulation. And if a patient has claustrophobia, then we could consider an open face mask that can help mitigate those symptoms. Further, an open face mask may allow for surface guidance in order to monitor for any patient motion during treatment if that technology is available. Outside of the brain and in the body, immobilization is super important too. So typically, immobilization for SBRT and SABR is performed with the patient supine, positioned straight, and secured so that they can hold still, yet are comfortable to also minimize any patient motion in response to being uncomfortable. Patients are typically immobilized in a body frame, as shown at left. This is standard practice at UT Southwestern where Dr. Lin works, or in an indexable vac lock bag, as shown below at right, as is done at Emory where I work. The patient arms are positioned outside of the treatment area, so we don't want to treat through the arms and deliver unnecessary dose. And additionally, we don't want to have dosimetric uncertainty due to differences in path length based on arms moving around within the field. So 2 considerations. Now, patient management for abdominal and thoracic tumors is very important because of the effects of cardiorespiratory motion. And we'll go into more detail on that. Okay, so what are some guidances? And here we're talking about image quality, and a high quality treatment plan in image set will encompass all of these relevant patient anatomy with minimal imaging artifacts. And so as part of this CT image quality check at simulation, we're looking for slice thickness that is typically under 2 millimeters. We use the smallest CT field of view that avoids image truncation. And so this is done in practice for SRS as that field of view is coned down to improve the spatial resolution. This is done for SBRT, but in practice, it's not as easy to cone down as much because the cross-sectional anatomy is larger and there are also immobilization devices in the field of view. Another question to ask is, are critical organs at risk with dose volume constraints fully imaged? So for example, if we're treating a lung tumor and there is a dose volume constraint placed on healthy lung, it is important to image the entire lung in order to evaluate the mean dose. Same would apply in the abdomen for liver and other targets in the chest and thorax for these parallel structures. Scan range needs to be about 15 centimeters above and below the target volume to allow for non-coplanar beams. It's important to evaluate for image artifacts like metal and motion, and then to evaluate for contrast that can be used to visualize the tumor or important organs at risk. It is very common to use multimodality imaging for SRS and SBRT. This could be MRI, PET, or ultrasound. Ideally, the same mobilization devices would be used for all the imaging studies. So immobilize at CT, then carry through to PET or MR with that same immobilization. In practice, though, this may not be feasible due to logistical concerns, meaning the patient could go to radiology first, or there could be scanner constraints. That is, the bore size may not accommodate the mobilization devices. Okay, so what about variable anatomy, and more specifically, the motion management? So if you're going to use motion management, so 4D CT simulation, it is so important to do end-to-end testing with a dynamic phantom first to commission the system before using it for patient care. Now, once this is done, then this provides very valuable patient-specific information. So respiratory motion effects really need to be accounted for abdominal and chest SBRT. Below are some examples from the AAPM Task Group Report 76 on respiratory motion and radiation oncology that gives the magnitude of motion in the abdomen and in the chest for different organs, and also within different organs, and here for lung, showing that there is greater motion near the diaphragm than up top near the apex. Okay, and so what about motion management for an individual patient? If you have the luxury of having 4D CT available, it's highly recommended to use per patient for SBRT in the chest and SBRT in the abdomen. The physicist is typically involved and is encouraged to be involved at the CT simulation. If the motion as determined by the 4D CT is less than 5 millimeters, then it's acceptable just to add a uniform margin. And in practice, we will typically use the 4D CT to define a custom margin. Now, if the motion is greater than 5 millimeters, then you really need to do something about it. Now, that could simply be adding an ITV that accounts to the patient-specific motion envelope as determined from 4D CT image, and then to treat for breathing. Compression can also be used, and this is a preferred form of motion management when the compression is adequate at reducing the motion. Breath hold may also be used. A recommendation is for the patient to be able to hold their breath for around 20 seconds, to be able to repeat that multiple times, and then to obtain an ITV for multiple repeat breath hold scans. Phase-gated treatments are also an option. The exhale phases tend to be more stable, so that is the valley in the cycle. And in practice, this would be performed without compression, at least on a varying machine, in order to have sufficient amplitude of the marker block to enable gating during treatment. Active motion tracking is possible on a CyberKnife machine. That is, the LINAC, the robot rocks back and forth to guide radiation to the moving target. For the rest of my talk, I'm primarily going to focus on Varian machines. Now, this is not an endorsement of Varian, rather it's a reflection of the technology that was available to me in my practice. So now,
Justin,
yes.
Before we enter the next slide, let's pause in the imaging. Can you go back one slide? Because there is a question in the chat. We can probably start first. So there's a question say, when doing image registration, what level of differences between CT and MR PET or PET is considered acceptable? And to what extent we can use the deformable registration? Justin, we lose you. Oh yeah, okay, back.
I do hear you, Dr. Lam.
Okay.
Let's see. Let's see if I can launch that. Okay. Let me launch this question number 1 on motion management. And that question is now active now. So the rank order of the questions have been reversed on the list. So we'll start from the bottom and go up. And so this first question is, what motion management strategy typically results in the shortest treatment time? And so this is in the context of, say, lung SBRT or liver SBRT, one of these disease sites in the chest or the abdomen.
Okay, so do you want to answer the question while we are doing the poll? So maybe I can start first. So to manage the difference between the CT or MR, primarily you will look at the area you are interested in. Number one is the target area. If you use the MRI or PET to facilitate the target contour, so the first thing you will look at your alignment in the target area to see if the despite the positioning may be different, but if you can get good registration in the area you are interested, and they are still it's still usable. So just avoid to use that register to an entire field of view, which will be definitely inaccurate if your patient set up differently between your CT scene versus your R or PET. But if you do the target alignment for the full registration, it will still be usable. Okay, and if the curvature of the body is so different, then you may not want to use it. So there is no absolute answer at what level, but it's really to the judgment of what do you use this MR or PET for the contour, and do you have confidence of the area you are interested is accurate enough for the contour? And then yes, yeah.
And then the second question, which I've launched, that I actually intended to fall within this section of the talk, is related to the motion management. And so abdominal compression is what would absolutely result in the shortest treatment time, because the beam stays on while the patient is compressed. With either deep inspiration breath hold or expiration breath hold or phase gating, the treatment beam is necessarily interrupted during part of that duty cycle. And the amount of that interruption depends in part on how well the patient breathes and can comply. It tends to be a little faster with breath hold than for phase gating. And so, for example, for lung SBRT, assuming that the patient's a good candidate, typically breath hold adds a couple of minutes onto the treatment, whereas phase gating could even add 10 or 20 minutes onto the treatment. And so I'm going to stop sharing the poll, and then I'm going to continue on with the talk. And if there are any questions in the chat, Dr. Lin, maybe we could talk about those just very briefly, and then pick up with some different concepts.
Okay, so there's a second question about when to use the deformable registration. The answer is for our institution, we actually use it anytime we need, but the key is really how you take the registration result. Is that a reasonable deformation or not? So there is no what case we use deform or not, but we do very careful QA when we review the registration result. We look at the deformation map to make to think about if those deformations are reasonable for the patient. If they are reasonable, then you could use that registration to help guide the contour. All right, Justin, I think we can continue on.
Okay, thank you. Okay. So it's very important to analyze the image set selected for treatment planning to ensure that that matches the patient position and the state that will be used for the treatment delivery, and that this aligns with the physician's intent. CT simulation studies can include multiple image sets. It is important to label each series clearly, and this is crucial for the planner to QA or to evaluate the scan to ensure that the correct data set's being used for treatment planning. It's also so important to transfer these images, the correct images that are needed for planning, to the treatment planning system or whatever software is used for contouring. Then it's important to verify that the correct image sets were used in the treatment plan. And in particular, this is important if the patient has underwent multiple imaging sessions. So for example, pre and post-surgery with repeat studies that could be due to errors or time lapse. And so what I mean by that is, for example, when I was in clinic, a physician asked for a PET CT to be brought in to create target volumes, but did not give the date. And the patient actually had a long series of PET CTs. And I first found the one which was most recent, and I asked the physician, is this what you need? And actually, it wasn't what they needed. They needed the pre-chemotherapy PET. So that communication is so critical with physicians and team members. And don't just assume that the image set that's selected is correct. It's so important to make sure that we have the correct one, the correct information for planning. The DICOM header contains very useful information that can be interrogated or investigated to look at things like the acquisition date, the number of slices in the image as compared to the summary note, and then evaluate the summary notes themselves to look for contrast or breath hold, to know which data sets are in fact needed for treatment planning. The DICOM convention is defined by NEMA. There's a link below that gives you a bit more information on DICOM. Okay, and so treatment planning. Accurate image registration is really critical to define targets using multiple imaging modalities and to generate sums with prior treatment plans. Multiple imaging modalities are used for SRS and SBRT planning. For SRS, high-resolution MRI, and more specifically, T1 weighted with gadolinium contrast is so important to delineate brain metastasis. For SBRT, depending on the disease site, PET, MRI, or maybe even ultrasound may be indicated. For dose accumulation, this is typically achieved using a CT to CT fusion or image registration. To reiterate Dr. Lin's point, it's very important to evaluate the accuracy of image registration for the intended purpose. That is, whether contouring targets, performing a dose deformation and accumulation, or to revise a treatment plan based on changing anatomy. Rigid registrations are sufficient for the brain, while the addition of deformable registration may be needed in the body. And it's so important to be critical of deformable registrations because the algorithms may not be biomechanical. That is, the images may look reasonable, but the vector fields may not be physically realistic. It's important to review the vectors. Verify that the correct images were registered. So whether it's pre-op or post-op, whether contrast or not, and then also ensure that the date of study aligns with what the physician wants for these complementary imaging sets. It's important to consider the clinical impact of the uncertainties in the registrations, for example, when selecting PTV margins. Okay, and so here is a Zoom poll number 2 for you all. And That Zoom poll has been launched by Dr. Lin, so go ahead and please vote. And the question is, what imaging modality is used to delineate brain metastasis for stereotactic radiosurgery?
So I think I can end the poll. For the result. Okay, Justin.
Okay, so the results, I believe, are shared right now. And the answer is number 3, which is T1 weighted MRI with gadolinium contrast. And so this is the imaging modality of choice for SRS to brain metastases. Thank you all for participating. I will stop the share and then continue on with the talk. Okay, so now let's discuss contouring. Accurate target structures ensure that the full extent of the tumor is treated. Accurate organ at risk structures are needed to ensure that normal tissue toxicity is minimized. The accuracy in this check refers to both the structure delineation, and below is a link to consensus contouring atlases that can be used to evaluate anatomical
Sorry,
boundaries.
Justin. There is a comment in the chat says cannot see the slides. I would like to check.
Okay. Okay. So there are contouring atlases available. And then accuracy also refers to the structure nomenclature. That is how we name the structures. And what we follow at Emory is the guidance from the double APM task group 63 in terms of how to name the structures. There's a fault mode that we need to be mindful of, and that is what you see is all there is. And so, for example, if we're looking at a structure list and going through and evaluating the accuracy of the anatomy that's been contoured, and then also checking the naming conventions, we also need to be looking to make sure that all the relevant anatomy has in fact been contoured and named as well. I mean, if a very important organ at risk is left off and this is inversely optimized, we have the potential to do harm and potentially not know about it. It's also important to verify the laterality of the contoured structures relative to the images. And so one example is with, say, abdominal SBRT, it may be that the patient has variable kidney function and we need to preferentially spare one of the kidneys. And if someone makes a mistake and mixes up the left and right naming convention, and the planner is not really paying attention to the actual laterality, then they could in fact spare the kidney that needs to be sacrificed and then really create a lot of harm to the patient. It's important to evaluate the target description in the patient's chart. And by that, I mean, look at the imaging report from radiology, the radiation oncologist's consult, et cetera, to ensure that the target volume really makes sense in terms of what should be treated. If you're ever in doubt, ask. The worst thing we can do is to assume and get it wrong. Talk to the physician, talk to the treatment planner, make sure that the structures are accurate. Okay. Missing or defective organs at risk and target structures can lead to unintended normal tissue toxicities and compromised tumor control. Again, refer to contouring atlases. CT is typically the primary imaging step for treatment planning. However, other imaging modalities really may be needed to visualize the important anatomy. And an example here at right is an MRI of the brain, which really shows much more clearly the boundaries of the brainstem and the optic chiasm that just cannot be delineated as easy on CT alone. When you evaluate these images with the structures overlaid, it's important to look for a mismatch or an offset, a misalignment across the different imaging modalities, because that could indicate that there's a problem with the fusion, which would then require further investigation and correction. It's important to identify missing slices, incomplete or erroneous interpolation, straight pixels, and that's especially true for the target volumes. Artificial intelligence for contouring is in the clinic now. However, a person still has to review and correct the AI contours. Shown at bottom right is an example of AI contouring for the bladder with the commercial software. You can see the bladder contour in purple that a human did, and then up top in yellow is AI. And I just have no idea what happened there, but it's very wrong. If you use AI, you have to check it and correct it when needed. And most of the time it works. Most of the time it works well, but be careful. It's also important to note that not everything that lights up on a PET scan, CT, or so on is actually a metastasis or a target. It's so important to consult with the radiologist for target definitions. Okay, what about contour margins? Selecting the proper margin is important to ensure that the treatment plan will strike the right balance between tumor control and minimizing toxicity. So ask the questions. Are the margins consistent with institutional and clinical trial guidelines? Are the margins implemented correctly in the planning system? And if there are asymmetric or custom margins, then those really need extra scrutiny. Let me show you a couple of examples. So in the bottom left is a brain case, an SRS case. It is a small brain metastasis. The clinical institutional guideline is to use a 1 millimeter margin, shown in blue, but if someone's having a bad day and they move the decimal place just by one spot, then that 1 millimeter can turn into 1 cm, and we can do a lot of harm to the patient with radionecrosis. Shown right is an ITV, and with this ITV for the lung, what's commonly done is from this ITV, which is shown in orange, that accounts for the motion envelope, the motion during the 4D scan of that gross disease. Typically, a 5 millimeter margin is added to create a PTV shown in red. And in this case, the person creating that expansion had a bad day. They did 5 millimeters everywhere but in the inferior direction. And then all of a sudden, we've missed, or we're too tight on that inferior border. It's so important to evaluate the margins. So what about immobilization devices and things that can attenuate the beam? Really, these supporting devices and immobilization devices should be considered in the dose calculation. For SRS, frameless immobilization systems are designed to have minimal attenuation. In practice, we do model the immobilization device in the treatment planning system, and this is done to account for the high density pins. For SBRT, the body frames, compression plates, couches, and other immobilization devices can have a measurable effect on the dose distribution. This is especially true for superficial targets, whereby these devices create a bolusing effect that can absolutely increase the skin dose and potentially create an ulcer or a wound that may not heal. It is good practice to include all these devices in the body contour or external contour, or to model them explicitly, and then to consider avoiding beam entry through these devices to avoid that bolusing effect. Okay, what about density overrides? The correct use of density overrides ensures that beam attenuation and dose deposition is correctly modeled in the dose calculation. What is truly important is the electron or the mass density override, not just the CT override, because it's the mass density for Acuros or the electron density for AAA, for example, that is ultimately what is the determining parameter in the dose calculation. On the CT images, a high Z material can have a saturated CT value. It's important to know what that material is to then use the correct override. Moreover, if contrast, whether it be iodine contrast through an IV, or barium contrast through a swallow, or other materials present in the simulation, we need to know if it's going to be present at treatment. And many times it's not, in which case this material should be overridden to the density of what will be there at treatment. So maybe it's nearly water equivalent or soft tissue equivalent for, say, the heart or the stomach, or it could be that there's a wire on the patient's surface that really should be modeled as air because that wire will not be there for treatment. Okay, now let's talk a bit more about beam settings. An ideal treatment technique aims to maximize therapeutic efficiency while minimizing harm. The modality of choice for SRS and SBRT is photons, not electrons. The technique may either be 3D conformal RT using static fields, cones, or dynamic conformal arcs, or it could be intensity modulated RT with static fields or arcs. Regardless, it is common to use beams from many directions to fill in the 4-pi space. I showed 2 examples below. On the left, many 3D conformal fields, and then on the right, mat arcs. An ideal beam arrangement will maximize target coverage and protect the organ at risk. It also needs to be efficient to deliver. And here are some considerations in terms of beam. It is fairly common to use coplanar beams for central targets and for targets which have natural barriers, whereas non-coplanar beams, as shown in the bottom row, may be preferred for the brain and for the lung and for disease sites which have tentacles. And that's really a philosophy that has been developed at UT Southwestern. So what about, or let's talk a little bit more about this beam arrangement. So dose conformity is super important for SRS and SBRT, but that needs to be balanced with organ at risk avoidance. So below, I show a lung SBRT case where it's a posterior target that's relatively close to the chest wall, but more importantly, it's close to the spinal cord. And by organ avoidance, what I mean is that the dose gradient is a little bit steeper in the direction of the spinal cord. However, overall, the isodose lines, in particular the 50% isodose line and above, those tend to be tight and fairly symmetrical in different directions going out from the PTP. Now, when an organ at risk is nearby, the exit dose is preferred over the entry dose, so try not to treat through an organ at risk to reach the target. And selecting shorter path lengths to a target can reduce the integral dose. So in this case, both of these arcs are 180 degrees, but in the plan shown at right, you can see that that 180 degrees has been shifted such that there's a component that comes from under the couch on the opposite side of the patient to avoid treating through the liver, while also avoiding spinal cord and at the same time shortening the path length to the target. This slide shows a lung SBRT case that has been planned with 3D conformal fields and a non-coplanar arrangement in the first column. The middle column shows coplanar VMAT arcs, and then at the far right is a non-coplanar VMAT technique. And what I really want to emphasize here is that the plan quality is very good for 3D conformal, for VMAT, whether it be coplanar or non-coplanar. And it may be that in this case, the 3D conformal actually has some advantages. And by that, the field apertures tend to be open, the MUs tend to be a bit lower. You don't necessarily need to be VMAT equipped to deliver lung SBRT. Okay, so
sorry, Justin, there is a question about it. Can you elaborate about what exactly meant by exit dose is preferred over the entrance dose?
oh yes, that is an excellent question. And what I mean by that is that let's say that we have 2 opposing gantry angles. And within that gantry beam's eye view, there's a target which we want to treat. And there is also an organ at risk. And so we get to pick one of those 2 opposing beam angles. What I'm suggesting to you is that we need to pick the gantry angle where the beam first encounters the target, and then beyond the target is the organ at risk. So that is, we're a little bit lower down on the percent depth dose curve by the time we reach the target, and therefore the dose of the target is lower than if we selected the opposite opposing angle, where the target would be hit higher up on the percent depth dose curve, or I'm sorry, the organ at risk would be hit with a higher dose higher up on the percent depth dose curve, followed by the target. Does that make sense? Or Dr. Lin, would you like to say it a little differently?
I think that makes sense to me. Awesome. So there
Okay.
is there is another question also about the beam arrangement from Hausa. Is it mandatory one arc to be 180 degree?
Okay.
Yeah.
So no, it is not mandatory. If you select a 180-degree arc, that tends to ensure that you have dose conformity. That is, the isodose lines tend to be more symmetric in all directions. It may be that there is an advantage from using a longer rotation, 360 degrees. I think Dr. Lin could talk about that. There
Yeah.
may be other cases where we have multiple arcs, some of which are 180, but then we have some of which are shorter, and that's used for organ avoidance or to avoid collisions.
Yeah, so it's really a balance between your beam conformality and your OER dose sparing. Saying if we go back one slide to the example in the previous slides. So in this case, if you have contralateral side beam contribution, your dose distribution will be more conformal to the target. That's the advantage. But of course, the disadvantage is that you're gonna irradiate the contralateral side of lung, and so that's really a balance. It's not meant to be 180. For our institution, we usually encourage you to have like a little bit over 180 degree, like the second on the right figure. You want to go a little bit over to the other side to have some entrance beam there and to pull the isodose distribution to be a bit conformal. But there is no one answer. I think I found a lot of that is really the preference of the physician. We choose full arc as like mandatory because our physician believes you need to give enough intermediate dose to kill the tentacle of the tumor. So that's why Dr. Timmerman really speak high about you need to have enough dose of like 70 isodose 9 to be also conformal. But then there is no direct outcome study to say you definitely need to do that. So ALARA is also important. Yeah. Okay, there is
Thank you,
one
Dr.
more.
Lin.
Okay, no problem. There's one more question about the beam. So, would you prefer to treat SRT patient use the FF beam with non-coplanar VMAT, or would you want to choose healthy on FF beam without the couch rotation, gives the advantage of the SRT? So I think
Well,
the
I will
question is like
touch on this a
coplanar,
little bit more in a
right?
future slide.
Yeah.
Let's
So let's
pause just
go
for a
ahead.
moment
Yeah.
and come back to that one. Okay. I strongly support non-coplanar beam arrangements for SRS and SBRT, but it has to be safe, it has to be deliverable, and you must avoid collisions. So any advantage in plant quality from a non-coplanar beam just simply disappears the moment the gantry touches the patient, touches the couch, or gets really close, right? And so there are strategies in place now to minimize the risk of a collision. One is to perform a dry run with the patient on the couch top. Another is to perform a virtual dry run using a CAD model of the LINAC, the couch, and the patient anatomy, say from a CT dataset. Or you may also consider using surface guidance, as shown at left with MapRT, that shows more comprehensively the patient anatomy in the LINAC. And these technologies might even be used during treatment to watch out for collisions. Whenever possible, you should evaluate collisions upfront in treatment planning and give the treatment planner this information so that from the get-go, they're creating a high-quality treatment plan using the best available beam arrangement, which is safe and deliverable. Okay, what about beam energy and dose rate? The high dose rate is preferred to minimize treatment time. Flattening filter free beams on a varying machine could be 1400 MUs per minute with 6 triple F, or 10 triple F could be as high as 24 MUs per minute. One philosophy is to use 10 triple F for the more deep-seated targets while using 6 triple F for the more superficial targets like those in the brain or the lung. However, in clinical practice, both 6 triple F and triple F are used across disease sites, whether it be SRS or SBRT. Okay, in terms of the beam arrangement in conjunction with dose rate, for peripheral disease sites which have tentacles and the brain, I am in favor of the non-coplanar beam arrangements because one, it creates a greater symmetry of the 50 and the 70% isodose lines that go superior and inferior, which would be lower if it were just coplanar. And the overall dose distribution tends to be more compact, more tighter by using that non-coplanar arrangement. But like Dr. Lin said, I don't know of clinical trial data that suggests that what we think may provide an advantage actually makes a meaningful difference in terms of clinical outcomes. I just don't know that. Okay, what else do we need to consider? We need to be looking at collimator angles in order to minimize the MLC motion. And an ideal collimator angle will allow the MLCs to conform to the target and to block the organs at risk. So what can be done? Well,
والله يقول في حاجة مهمة يا أخرج.
we can rotate the collimator so that the MLC conforms to the target and blocks the healthy tissues in between. And so see the example at the bottom for a multi-target SRS case where the initial collimator rotation is such that the MLC opens up to treat both targets and then inadvertently irradiates the healthy tissues in the middle. Whereas at right, the collimator has been rotated approximately 9 degrees in order to block the healthy tissues in between. We tend to position the isocenter in conjunction with this collimator rotation such that the inner, more narrow MLC leaves are used to shape the beam. And we also avoid a 0-degree collimator angle so that there is not superposition of the tongue and groove effect, which could create uncertainty in the dose. It's important to review the MLC shapes and trajectories in the beam's eye view to spot problems that could impact plan quality. I strongly recommend to evaluate the beam's eye view for every field or arc angle. We want to see that the MLC travel is adequate for field shaping, and this is of greater concern when there are multiple targets, disjointed targets in a single plan, like was shown on the last slide. By looking at the beam's eye view, it may be possible to find MLC openings outside the target volume that could be caused by a stray PTB voxel. And so that's what I'm showing in this example below. So you can see this large blue PTB that represents an SRS target volume. And then you can see that one of the leaves opens up, and that's opening up to treat this really, really tiny dot where there's a stray contour that was just wasn't caught by the physician during the volume definition. Smaller apertures can have greater dosimetric uncertainty. And so all things being equal, if you can achieve the same plan quality with a slightly larger aperture, then that's recommended. So overmodulation can lead to increased treatment time, patient dose through increased leakage and scatter, and can increase the demands on the LINAC. So what do I mean by modulation factor? So we want to verify that this modulation factor, which can be defined as monitor units per prescribed fraction dose in centigram, is within the expected range for the modality in the treatment slide. A high modulation factor can result in a poor plan QA with lower passing rates and a loss of plan robustness. Ideally, you would want to collect modulation factors from your clinic in order to anticipate what's expected for a prospective plan for a new case. And we should expect a lower factor for single targets when an organ at risk is not dose limiting. That is, this is a plan where dose conformity is the primary objective. That may be as low as 2 MUs per C-grade for a peripheral long SBRT plan. And these factors could be higher for multi-met SRS or spine SBRT, where it might be a factor of 4 or even 5. Whenever the modulation factor is higher than expected, you might consider another plan. And within that plan, you could consider penalizing the monitor units or relaxing optimization priorities. Now, if you're using Eclipse, and if you're on version 16 and have GPUs, be careful. There's a bug that if the MU penalty is used in conjunction with the GPU, then it's possible to have plans which diverge, do not converge to a good solution, and plan quality can be really, really bad. So watch out for this. Now, what about optimization objectives? Objectives for the target should be set sometimes upper and certainly lower bounds. And these upper bounds should reflect the planning intent, whether it's homogeneous dose or whether we allow the dose to be really hot in the center of the field. Goals for maximum and min dose are typically stated in the RTOG protocols or clinical trial protocols, so this should be a good basis for guiding your practice. There may be institutional variation based on physician preferences that could influence this to some degree. For SRS and SBRT, the targets may only require lower objectives. It's important to review the necessity of an upper objective and why. Why is that? Well, the objective is to establish a very steep dose gradient around the target. And this is not as easy to do or as possible even if we restrict the hotspot, that is, we make the dose homogeneous. Making a uniform PTV dose at the prescription level will absolutely make the dose gradient more shallow, and that can lead to toxicity to the healthy tissues nearby. So what about the objectives for the organs at risk? Well, when target avoidance is important to meeting clinical goals, the OAR should have appropriate DVH and mean dose objectives placed. If an OAR abuts or overlaps the target, then that OAR objective should be much smaller than the respective target in order to reduce dose. In general, we want to follow the principles of ALARA, but more specifically, the literature that you want to reference is high-tech, or the clinical trial protocols, in order to know the clinical goals for these organs at risk. These goals are absolutely different than with conventional RT. They are not the same. So high-tech stands for hypofractionated treatment effects in the clinic. It may not be possible to meet the OAR constraints in the overlap region without affecting target coverage. And so when this happens, the good practice is to contour this overlap region separately and to optimize separately that region as compared to the OAR and to the PTB. Okay, so here is just an example where I show site-specific guidelines in terms of spinal cord dose constraints from TG 101. I don't want to spend a lot of time on this. I just want you to know it's not the typical 45 to 50 gray from conventional fractionation schemes. These values are lower, and they become progressively lower as the number of fractions is reduced. That same concept applies to all the other healthy tissues throughout the body. And you can reference APM Task Group 101, high-tech, and clinical trial protocols to get these quantitative clinical goals for your practice. Okay, and so what else do we need to do? Well, we should focus on what matters most. And by that, weight should be given to each objective to reflect the priority of that clinical goal. And so here's an example showing rank order of the importance of the clinical goals in terms of target coverage and sparing of organ at risk. This information should be shared upfront in treatment planning The rank order of the optimization priorities, that is the weight that you put on the optimization objectives, is important, but it is less important than the end result. That is how these clinical goals are achieved. And encourage your MDs to rank these clinical goals so that this information can be formulated as a checklist on a document or even integrated into the treatment planning system. Okay. We also need to review the optimization for any structures that may have been missed and not penalized. It could be an oversight. So that's the example I show at left where the spinal cord, so super important, and it just wasn't penalized. This could be catastrophic for the patient. And then it could be intentional. So at right, I show an example of a long SBRT plan where there's not an organ at risk nearby, which is dose limiting. Only 2 optimization objectives were needed for this plan to achieve a very steep dose gradient in all directions. And there just simply wasn't a need for extra penalties. And what about conflicting objectives? These are important too. Now, it could be a mistake, but more often it's the result of proximity of the target to an organ at risk. So for example, if they abut or if they overlap. And that's what I show in this example below, where the PTV prescription is 50 gray, but yet the heart max dose is only 38 gray. And then we have an overlap region where it's just simply not possible to achieve both. And it's important to know the rank order of those clinical goals. And a tip from a planning strategy is to segment out the overlap region or the region where there's conflicting penalties and to optimize that with different values as compared to either the target or the organ at risk outside the overlap region. So think SIB or simultaneous integrated boost. Okay. Dose conformity is super important with SRS, SBRT. There are multiple ways of penalizing the dose gradient. It could be concentric rings or shells, whereas that ring or that shell, as it gets farther away from the target surface, then the dose is penalized to a progressively lower level. Within the variant treatment planning system Eclipse, you could use the normal tissue objective function. If you do that, avoid the automatic NTO. Could also use a mean dose objective placed on the organ at risk that surrounds the target. So here's a caveat. Regardless of which of these techniques you use, and you may use multiple in combination, the settings matter. And so below I show an example of the NTO. So this is a 1D gradient penalty where the fall-off value is altered across the same plan. And what I show in the first example in the upper left is a very asymmetric dose distribution where the 50% line spills out quite a bit in the APPA direction. This dose conformity really is not good. And then next to it, exact same case, a different NTO fall-off value. You note the symmetry, the tightness of those isodose lines. This really is good dose conformity. Okay, so here's Zoom poll question number 3. And this relates to, let me read this off. Which of the following techniques is not used to create a highly conformal dose distribution with a steep dose gradient? So we've talked about 3 different techniques that are appropriate, that are used to create very steep dose gradients. But one of these just simply does not do a good job. It does not align with that goal. And so within this question, there's kind of this implicit understanding that if you use one of the recommended techniques, that you're using it well. And there's also the possibility of using these other techniques and not getting the settings quite right and not having good dose conformity. That's also true too. But there's one of these techniques that always works against the dose gradient. And that's really what I'm after with this question.
Right, so we give like 30 more seconds for the answering question. And then meanwhile, just a reminder, don't forget to sign attendance. Let me repost it, the link again. And there is a question in the chat about the gradient index and the CI formulas, and I know Justin has an upcoming slide for that. Let's wait for that, and he will add your question into the slides to explain it. Okay. So we have 109 people, 110. Yeah, answer the poll. And if you cannot see the question or you cannot see the poll, you can answer in the chat.
I recognize that we're covering a tremendous amount of material and that this talk may go a little bit long today, and I certainly respect your time. If you need to leave, feel free to do so. We're going to continue to record. If you have questions later, please share those with me or Dr. Lin.
Right, so let me end the poll now and share the result.
Okay. And so the answer is number 4. That is a max dose penalty on the PTV at the prescription dose level. That is trying to achieve uniform PTV dose will absolutely compromise on the dose gradient. It will make the dose gradient more shallow. It will increase the dose to the healthy tissues nearby if you try to achieve a uniform PTV dose. Okay, let's talk more about the dose distribution. The prescription dose should match the physician's planning directive and the normalization method. You can verify the planned prescription or normalization method is appropriate based on what's being treated. And this can be different for SRS, long SBRT, fine SBRT. Refer to high-tech and to clinical trial protocols for knowing what's recommended in terms of normalization, especially the clinical trial protocols. The dose calculation and the grid size are important, and this can be different than with conventional RT. It's recommended to use dose calculation algorithms such as collapse cone, Acros, or Monte Carlo, especially when the path length through heterogeneities is substantial. So think lung, the dome of liver, nasopharynx. Pencil beam is not recommended in these settings. The recommended dose grid size is 2 millimeters or smaller, perhaps even 1 millimeter for SRS. A grid spacing of greater than 3 millimeters is discouraged. This will absolutely increase computational time by using a finer dose grid. One strategy that you may use is to perform initial plan iterations on the course grid in order to explore different beam geometries and optimization settings, and then fine-tune and polish that plan on the finer grid that takes longer time for the calculation. Let's talk about target coverage and conformity. This also goes exactly back to the question of halcyon versus non-coplanar with couch kicks on a Linac, like an L-shaped gantry Linac. Okay, so I'm showing 3 examples. This is an SRS case. On the left column is a coplanar arrangement. In the middle is non-coplanar with couch kicks. Then at the far right is non-coplanar with shallow couch kicks. Because of this high dose refraction, dose conformity needs to be evaluated all the isodose lines, so not just the prescription isodose line. You should refer to the clinical trials for the exact recommendations. But now that we're looking at all these isodose lines, what I want to point out is this. Excellent high dose conformity at one isodose line does not guarantee adequate dose conformity at the lower isodose lines. In this example, these green lines perfectly overlap the 3 disjointed SRS targets, as the prescription dose conformity is excellent. However, at the 50% isodose line, which is associated with rates of radionecrosis for single fraction SRS, you can see that there is a very different shape or very different conformity. And the red line is most compact with the non-coplanar beam arrangement. And you may be thinking, well, you're not showing me the dose outside of this plane where there's exit dose for non-coplanar. That's true. But take my word for it, the volume of this red line is absolutely smaller using the non-coplanar beams. And for that reason, that's why we strongly recommend non-coplanar beam arrangements for SRS. Okay, so this should be a pretty easy follow-up question for you. True or false? Acceptable dose conformity at one isodose level ensures acceptable dose conformity at other isodose levels.
All right.
And this answer is false. Just because the prescription isodose line matches the shape of the target, that does not guarantee that the dose distribution is compact, and you absolutely should be looking at lower isodose levels. Okay, there are a number of metrics out there that can be used to evaluate the dose gradient or the conformity, one of which is the gradient index. And so this is the ratio of the volume of the 50% isodose line relative to the volume of the 100% isodose line. Lower is better. It could be a Paddock conformity index. So here we're looking at the conformity of the prescription isodose line and not only accounting for the size and shape of it, but also for its spatial overlap with the target volume. R50 is simply the ratio of the 50% isodose line relative to the volume of the PTV. This is a common metric for long SBRT that can be used for other SBRT plans as well. Lower is better with R50. And below are some references that describe not only these metrics, but also give some benchmark clinical data that you could be used to compare with cases in your clinics. Okay, good target coverage improves tumor control, while high conformality of the dose minimizes normal tissue toxicity. Both need to be reviewed carefully. So this consideration varies.
Sorry, Justin, there is a follow-up question about the CI. Should they use the RTOG formula or Paddock formula? Do you have opinion? Yeah.
Both of these metrics can be used for evaluating plan quality. Paddock has the additional built-in check of the spatial overlap. So in that sense, it's a bit more robust. And by what I mean by that is that if we use the RTOG definition, then we could have an isodose line that perfectly matches the shape and size of the target, but not overlap it and have a very good score. Now, if you're using normalization appropriately and it's a good plan, then there should be good plan quality from using the RTOG metric for evaluation. What you should expect in terms of numbers or values for these metrics very much varies based on the disease side. It very much varies based on the metric that's being used. And we really don't have time to cover all those details right now, but I think we could save that for follow-up later. Okay.
Okay, and yeah, the gradient, I think you will cover gradient in upcoming slides. Yeah. The question is about perfect gradient. What is the perfect gradient for SRS? And I will answer the modulation factor question in the chat. I will type that answer. Okay, thank you.
Okay, thank you. Okay, so goals for target coverage very much depend on disease side. So in the historic spine SBRT trials, it might only be that the target was covered 90% by the prescription isodose line, whereas that coverage was recommended to be higher for, say, long SBRT. These are also two examples that somewhat show the extremes between organ avoidance and dose conformity. So on the left, the top priority is organ avoidance. That is a very steep gradient in the direction of the spine. Therefore, the dose gradient is allowed to be more shallow in other directions. Whereas at right, we're looking for a very compact symmetrical dose distribution because there's not an organ at risk, which is dose limiting. Okay, so the dose gradient should be steep for SRS and SBRT. In the steepest region of the dose gradient, you should expect somewhere on the order of 10% dose change per millimeter. It may even be a 20% dose change for a small SRS target. It can be larger for SBRT. For SRS plans, it's important to look for dose bridging between disjointed targets because this is associated with an increased risk of toxicity, for example, radionecrosis. This is associated with the volume receiving 12 gray or even 10 gray. There are multiple strategies that can be used to mitigate these effects. Think back to the slide on collimated rotation. Rotate so the MLC blocks the healthy tissues in between. We can use a penalty structure in between these disjointed targets to reduce dose. And we want to minimize beams that simultaneously treat both targets, right? So minimize that dosimetric crosstalk. Rotations matter. Rotations matter in general for SRS. Rotations matter especially when multiple targets are treated with one plan. So if you think of these targets as being spheres, and let's say we treat these targets individually, the example of the green circle, then a rotation about a green circle is still a green circle. But what if we're treating multiple yellow circles? There's a lever arm. That lever arm creates a displacement. That lever arm can absolutely move the target out of the high dose region, even when the rotation is relatively small, say on the order of 1 to 2 degrees. So this is something that we studied a few years ago. Rotations matter. It matters both in terms of patient positioning, it matters in terms of accuracy of image registration and the machine mechanicals. Okay. It's important to review hotspots and to make sure that there's not dose streaking that results in high dose to healthy tissues. And we want to review both the magnitude and the location of these effects. So with SRS and SBRT, the hotspot can be very large, but ideally it should be inside of the GTV and at a minimum inside of the PTV. Planning techniques can be used to focus the high dose on the gross disease. And so in this example that I'm showing here, the lower objective was placed on the GTV. A dynamic NTO can be used. That publication's under review right now. And all I want to point out is that using these techniques, it's possible to concentrate that high dose on the gross disease as shown in figure B, and as compared to an optimization strategy that has high dose inside the PTV, but not on the gross disease as shown in A at left. Okay, when a plan cannot meet all the clinical goals, it's important to make sure that the higher priority goals are met first. So we want to confirm that the organs at risk are spared as much as possible in order of clinical priority. Refer to HITECH, the 2021 Timmerman tables, APM TG 101. OAR doses should be as low as possible without compromising treatment outcomes. It's not acceptable to simply stop the optimization when OAR doses are just below the tolerance, as this will make it very challenging if the patient needs additional radiation in the future, and it could increase toxicity risk for the current plan by itself. Conversely, and this is also very important, underdosing the target may result in recurrent or persistent disease, and that is devastating to the patient. So there has to be a balance based on the priorities. Again, I want to reiterate, you must review the dose bath at multiple isodose levels. Some recommended levels are the 100% line, 70% isodose line, 50%, and even the 30% isodose levels. So what about dose summations? Well, it's absolutely critical to account for prior RT in the current plan. It's important to verify that the composite plan considers the biological dose when combining plans from different fractionation schemes. Now, the biological modeling, this is done by converting physical doses to two gray per fraction equivalent doses, or EQDQ, or to biologically effective doses, BED. And depending on the organ at risk, there may be clinical data that's better for either EQDQ or BED. So you may have to do both in clinical practice. And so this requires input on the alpha beta ratios and any tissue recovery factors accounting for healthy tissue repair between the prior RT and the current plan. This type of modeling can be conservative, so based on a DVH, in which case you assume that the high dose overlaps. As the DVHs don't have spatial information, worst case is you pull the high dose tail off the DVH and use that for modeling. Or it could be on a per voxel basis, in which case we really need to be careful that the registration is accurate and appropriate with the prior plan. Commercial solutions are becoming more common. Some examples are velocity min, reformation, maybe even some of the TPS systems. Okay, so when this is done, what we want to do is verify the plan is safe by reviewing the accumulated dose from all the courses of prior RT that abut or overlap. And we should calculate constraints for a new plan and give that to the treatment planner based on the prior RT and provide this information upfront in planning. Below are some references that you can refer to offline on how to handle prior RT. Okay, communication. Communicate relevant plan information to the therapist to ensure the treatment plan is faithfully executed in the real world. It's so important to have written standard operating procedures that go from simulation to treatment planning to treatment and cover the quality assurance procedures too. Confirm that the necessary information is communicated to the therapist to maintain high quality. Clearly document the details. A photo is worth 1,000 words. Take pictures at CT Sim. Have an established source of truth for the important information so everybody knows where to look, whether this is an alert that's shown in the machine or in a document or in a prescription. Have a process in place for when plans change, and they may. If breath hold becomes compression, or if there are revisions to the prescriptions or setup and notes or alerts, it's important that people know when a change happens and then that they take corrective action. For unusual or complex cases, communicate directly with the therapist and other team members. So for example, if there's a risk of collisions, patient's the most important participant. Ask the patient at the time of treatment, what's being treated today? It's so important to know the disease site, the laterality, this, the right patient. We have to get all those details right. There are patient conditions that may affect the daily setup. The patient may not be able to keep the arms over their head. They may be claustrophobic. And so there could be requirements for pre-treatment imaging, including structures and planning fiducials to use for patient alignment that need to be considered. There could be organs that require special attention due to their proximity to the high-dose area, like the cord, the bowel. So it may be that the match at the machine, yes, needs to consider alignment of the target volume, but we may be so close to spinal cord constraint or bowel constraint that that takes priority, maybe even greater priority. There can be limitations, even if you have surface guidance, where certain gantry angles may block the camera, in which case you need to have workaround strategies so the therapists and the physicians know what to expect and know what to do. And when there are plans with multiple ISIS centers, there needs to be a warning to make sure that we're on the same page, that we know what we're treating, and that the setup notes and the pictures are accurate and they're specific to the correct ISIS center. And incidence learning. So mistakes can happen. Mistakes will happen. Hopefully those are not mistakes that actually reach a patient, that these are mistakes that are caught up front in these plan quality checks. So that's what we're talking about today. What you need to do is to keep a record of what's discovered during the plan quality review in order to drive future quality improvement. SRS and SBRT plans present greater risks due to higher dose per fraction, so there's a greater chance of normal tissue toxicity. A limited number of fractions, there's a reduced chance to recover. The margins are tight. There's the potential for misalignment to miss. Collisions due to these non-coplanar beams and extra mobilization devices. And added complexity, and this added complexity necessarily means that we need to be talking to each other. So there's this human element in the communication process that really needs to be codified and formalized. Safety and quality are no accident. They require substantial investments from equipment to program development to continuing education and adequate time in your clinical workflow to ensure safety and quality for patient care. When mistakes happen, acknowledge, investigate, and learn. Highly recommend a formal incidents learning system. Royals is an example that the AEPM and Astro have rolled out. What we use in our system at Emory is something called SAFE for reporting. So whenever there's a mistake, even if that mistake is minor, and even if it never makes it through an early stage of treatment planning, we always report, we always discuss, we investigate, we try to do better next time.